Okay, I'd like to start by going over some of my disclosures. So I would like to mention that the study that I'm going to talk about today was a study out of two of the Hopkins ERs and was funded by ImmuneArray. And I'm also the PI on NARSAD Young Investigator Award that's been funded by the Brain Behavior Research Foundation. So when I first started out in the brain injury clinic several years ago, I encountered several patients, but one that was very striking was a man who was quite accomplished in his career, had done very well financially and built a very successful business. And he was T-boned and had a brief loss of consciousness from a mere 3 to 4 seconds. But what ensued afterwards for him was a quite debilitating course. He suffered lots of headaches, light sensitivity, mood problems, sleep problems. And what was very striking, not just to him, but to all his clinicians, is how someone could suffer from such debilitating consequences just from a mild traumatic brain injury. So today we hope that we can cover some of the identifying some of the neuropsychiatric disturbances that we see after mild TBI within the first year of injury. And I'll use the word mild TBI and concussion interchangeably. There's some conversation about that, but for the purposes of today, we'll use them interchangeably. We'll identify some of the clinical and demographic risk factors associated with the development of neuropsychiatric disturbances, specifically within the year of mild TBI, and why it's important to learn about this particular group of people. And finally, list the pharmacologic and psychosocial interventions used to treat these symptoms. We'll first start off going over the epidemiology just broadly of traumatic brain injury, and then some of the risk factors for people who do develop concussive symptoms. Then I'll go over the Hopkins longitudinal cohort study that we did here, and then move over to talking about some of the management strategies and the future directions in this field. So what do we know now about TBI? Well, first of all, it's a very debilitating and very problematic disorder and illness. About 3.6 million TBIs occur in the US annually, so it's a big public health problem. About 3.2 to 5.3 million people live with TBI-related disability, and it's a very expensive disorder. So we have $60 to $221 billion that are spent in annual direct and indirect medical costs. This can include people who are discharged from the ERs, going into the neurosurgical units, people who are going to the rehab units. So all around, from all aspects of care, it is quite expensive. And about 43% of those who are hospitalized for TBI end up developing some kind of functional or psychological sequelae, which we'll get into today. And it is the leading cause of death and disability in people younger than 45 in the US. When we talk about sort of causes of TBI, we want to think about who are at the highest risk of suffering injuries. So the first are people who are in the geriatric population and tend to fall very frequently. Secondly, we often see people who suffer motor vehicle accidents, either they're the driver or the passenger, belted or unbelted. And then assault, depending on what the city crime rates are and how often assaults can occur. Assault is something else you want to be thinking about with patients. Finally, this other category of unknown is what we'll get into a little bit more later on, which is this concept of contact injuries in sports specifically, for example, with repetitive head injuries, as these can also become very problematic. So why is it important to understand psychiatric problems after TBI? Well, first you can think about the TBI as sort of this devastating event that happens to the patient, and whether or not there were psychiatric problems that existed prior to the injury, a combination of TBI and psychiatric problems afterwards can result in significant disabilities. Individuals can have vocational impairments, problems with social integration, participating in the workforce, and really thriving in their activities of daily living. It really can impact the quality of life significantly. So we have to start by talking about what is the definition of a traumatic brain injury. What is TBI defined as? So the most important point to make here is that it's a clinical diagnosis. There are several classification systems, the VA-DOD, Mayo, WHO, ACRM, but across the board, majority of the classification systems agree on the fact that you have to have at least one of the three: loss of consciousness. This is where we ask people, did you black out? A loss of memory immediately before or after the accident. So this is what we consider post-traumatic amnesia. And any alteration in mental state. Oftentimes we ask patients, were you seeing stars? Were you dazed, disoriented, or confused? And there may or may not be a presence of any transient focal neurological deficits or positive head imaging findings. A very common definition system is the VA-DOD. And when we look at severity of TBI from mild, moderate, severe, it's really about the duration of symptoms of loss of consciousness, altered mental status, and post-traumatic amnesia, really being within less than 30 minutes of loss of consciousness and less than 24 hours for the latter two. And typically with mild TBI, there's really normal structural imaging. And the Glasgow Coma Scale is typically used to sort of assess eye, motor, and verbal movement, with 3 being the lowest score and 15 being the highest. So anywhere from 13 to 15 is really where people with mild TBI often fall. However, you don't necessarily need to have the GCS to really define the severity. It helps if the other 3 are not clear. There are several ways one can suffer an injury, both looking at it from a mechanistic standpoint. So from a focal aspect, we see things like cerebral contusions. You can consider this more like a bruise to the brain, if you will, or hematomas such as subdurals, epidurals, intracerebrals, with intracerebral being the most debilitating with a lot of consequences ensuing afterwards. The other type is sort of a diffuse. So this can happen when you have an acceleration deceleration injury. If you think about the brain and this hard encasement of the skull, the sloshing back and forth can result in a lot of diffuse axonal shearing, which often we do see in concussions because there isn't necessarily a blunt force to the front of the head. There's just more acceleration deceleration injuries happening within the skull. So this is a very important point here, which is that when we talk about common neuropsychiatric disturbances after TBI, we can sort of put them into 4 big buckets: emotional, cognitive, behavioral, and physical. And it is important to think about the physical aspects, because if somebody had sustained an injury to the head, very likely their body was injured as well. So you want to think about orthopedic injuries and chronic pain. But the most important thing that will determine how well a patient does after a TBI is contingent upon what happened before the injury, at the time of the injury, and after the injury. And this is a lot of what we'll get into today. We can sort of divide pathology based on symptoms that we see versus syndromes that we see. So common symptoms that we see are things like emotional discontrol with affective lability, patients that have a legitimate reason to have a response, and it's appropriate emotional response. It just occurs in a very high intensity. Then there's pathological laughter and crying, in which a patient has excessive laughter or crying really in response to trivial stimuli that's incongruent with the stimulus that's occurring. And then there's irritability, patients that can get very easily on edge. Behavioral dyscontrol, this is what ended up putting people in the emergency departments or admitted to psychiatric units, which are things like aggression, agitation, as well as disinhibition, such as hypersexual behaviors and things like that. And finally, the cognitive piece is also significant. We see slower processing speeds, poor verbal learning, and impaired executive function. So people have a difficult time with task initiation, task completion, et cetera. So these are things to sort of be on the lookout for. From a syndromal perspective, we can pretty much say that people that have TBIs are really at higher risk of developing psychiatric syndrome. So when you compare the prevalence in the general population to those who have TBI, typically they tend to be higher. So major depression, for example, is the most common post-TBI neuropsychiatric syndrome, followed by anxiety disorders and substance abuse, as well as new behavior problems. Mania and schizophrenia not so common. So what is it that psychiatrists need to know about mild TBI? What's important about the presence of the most mild severity of this particular disorder? So about 70 to 90% of all TBIs are mild TBI. So it's really one of the most common, and it is the most common severity of TBI. So if you see patients with TBI, they're likely to have a mild TBI. About 42 million mild TBIs exist worldwide annually, and about 100 to 300 per 100,000 population are hospital treated. The problem is that these symptoms can often be refractory to traditional treatments that we might consider in patients that don't have TBI. And they're often overlooked and minimized. So patients come into the ER with a concussion, they're evaluated, but often discharged and asked to sort of, follow up outpatient. But as a result, there is a large variance in the persistence and severity of symptomatology. So who's going to persist with symptoms, how severe are they going to be, it's a very heterogeneous group of individuals. And finally, there's devastating functional consequences. Despite being mild, you do start to see people who have problems with functional outcomes, with activities of daily living, and high risks for suicide. So there's a conglomeration of symptoms that happen after a concussion, which we call post-concussive symptoms, which I'll be referring to as PCS henceforth, which is a combination of both neurological and psychiatric phenomena. So we see headaches, dizziness, tinnitus, diplopia, photophobia, loss of concentration, memory changes, fatigue, irritability, mood changes, as well as sleep disturbances. So when we think about the post-concussive sort of collection of symptoms, that's what we sort of want to be looking at. Often, however, these symptoms do resolve for a majority of people within 7 to 10 days after injury. And that's pretty much what makes this entire entity very complicated, because there is still a measurable minority, about 10 to 15% of people who still have persistent symptoms, such as my patient and pretty much many of the patients that are in our clinics at 3 months and beyond. And for those that symptoms that do persist, functional impairment can pretty much be existent in about 33% at 3 months. So who's really at risk for developing post-concussive syndrome? So this constellation of symptoms that continue to persist, who's at highest risk? So the literature has really looked at this and delved more recently into demographic risk factors. So poor education, substance abuse, people who had a prior TBI psychiatric history, either depression or anxiety, substance use, comorbid sleep problems, cognitive problems, and mood changes. Pretty much the two ends of the age spectrum. So those who are older or those who are younger, such as adolescents, are at higher risk. Females have been, in the recent studies that have been done, found to be at higher risk. And then there's a group of people that have complicated mild TBI. So these are people who still fit the criteria of mild TBI based on the duration of loss of consciousness, post-traumatic amnesia, and altered mental status, but their imaging findings might be abnormal. So they might have the evidence of a contusion, a hematoma, or some kind of a diffuse axonal injury. And finally, and this is a group that's really important to think about, are those that get repetitive TBIs. Repetitive TBIs typically tend to be those people who sustain these typically tend to be those individuals who have a cumulative effect of concussive symptomatology that can tend to linger for several years and beyond and really promote disability. So this concept of repetitive TBI is really something that's been up and coming in the media and a large topic of discussion. In 1923, Martland had coined the term punch-drunk state in individuals who were boxers and were suffering tremors, gait ataxia, pyramidal dysfunction, but had normal intelligence. And punch-drunk syndrome was found in people who were essentially getting repetitive hits to the head. So people that were football players, boxers, military personnel who were suffering blast injuries. In 1937, Millspaugh coined the term dementia pugilistica, which was really characterized by motor deficits and cognitive dysfunction. But the true neuropathology was sort of identified by Corsellis, who described this as a distinct disorder from a neuropathological standpoint. For example, noticing septum pellucidum abnormalities, scarring of the lateral cerebellar lobes, neurofibrillary tangles in the cerebral cortex that were diffuse, and the absence of Lewy bodies. But over the course of the years, the term has sort of evolved into this concept of chronic traumatic encephalopathy. And it's really now characterized as a broad range of neuropsychiatric symptoms of depression, apathy, social withdrawal, poor judgment, irritability, anger, and aggression, and violence as well towards others, as well as cognitive impairments, and combined with the gait disorders that we were seeing in the early cases that were seen by Martland and Millspaugh. So there's no question that CTE kind of has evolved to become very devastating in patients. McKee and Omalu, who are sort of the original researchers in this area, really started to define this as a neuropathologically distinct entity, specifically a progressive tauopathy. And McKee originally analyzed 85 postmortem brains in individuals who had suffered repetitive mild TBI. About 21 of them were veterans. And of those, about 15% or 15 of participants or 15 subjects had pure CTE pathology. In other words, the progressive tauopathies that were starting to be seen were in 15% of them. Others sort of had a combination of CTE plus other types of neuropathology, Alzheimer's dementia, and other types of dementia. And 15 really had no pathology. In a more recent study in 2017, McKee's group ended up expanding on the brain bank. So this is a brain bank that has looked at post-mortem samples. And this really looked at 202 former NFL players, 177 of which had at least CTE neuropathology. It's important to point out that these were sort of, which is 80% of the population or the sample, which is important to point out that these were patients who were samples of convenience. So these were families who donated their family members' brains for analysis, but they were sort of in the context of recollection of behavioral, emotional, and cognitive symptoms that the patients were experiencing. What's also important to notice is that the severity of CTE pathology that was found in this study was distributed across all the highest levels of play, with all former high school players having the most mild pathology and the more professional players having more severe, indicating that sort of a longitudinal course of repetitive hits to the head was really what was deeming the vulnerability to be more problematic in these individuals. So when we look at sort of the macroscopic changes of a normal brain versus CTE, what we are starting to see is that there's sort of dilatation of ventricles. There's a cave in septum pellucidum that you see down here across the midline, atrophies of the frontal and medial temporal structures, as well as shrinkage of the mammillary bodies. Microscopically, we see widespread neuronal loss and gliosis, extensive tau deposition, as well as this protein called TDP43, which has also now been sort of defined as pathognomonic in this kind of pathology. We also see a paucity of A beta deposition here as well. You look at the normal brain versus the CTE brain. So all this to really say that this is the most extreme of concussive symptomatology and pathology, and that a repetitive longitudinal course might render someone the most vulnerable. But repetitive TBIs is something to think about, and it is something to sort of keep in the back of our minds when we're asking clinically a patient's course. Now we'll pivot to what we know just about mild TBI in general, in terms of the phenomena that present and how patient trajectories end up coming about. So I'll talk about the head injury serum markers in response to trauma, or the Head SMART study, which is a very large study we did out of 2 Hopkins ERs, the Johns Hopkins Bayview ER, as well as the downtown ER. We screened about 4,452 participants, and the original purpose of the study that was funded by ImmuneArray was to look at blood biomarkers in response to trauma and see what psychiatric outcomes ensued afterwards. Several of us have done analyses from this data set to look at various aspects of the cohort, because it really does enlighten us as to what this particular cohort TBI looks like. At the end, about 500 enrolled, and when you applied VA-DoD criteria, just as we see with the literature, majority of the participants had mild TBI. So about 407 participants out of 500 had mild TBI, and 58 had moderate TBI. So going back to the definition of the VA-DoD definition, again, we're looking at a very brief loss of consciousness, less than 30 minutes, a very brief alteration of mental state and post-traumatic amnesia, and the structural imaging being normal. So everyone that met this criteria fell into the category of mild TBI, and the Glasgow Coma Scale ranging from 13 to 15, with 15 being the perfect score. So I'll go over some of the outcome measures and the instruments that we looked at. The first being the River-Mead Post-Concussion Scale. So this is a scale that looks at all the symptoms that we just talked about, ranging from all the neurologic to the psychiatric symptomatology. And really, it's a large 60-item scale, but we considered the scores to be significant if there were mild or more severe problems in at least 2 or more categories based on the ICD-9. So it's a very clinically useful scale, but also useful for trajectory progression when you're tracking the trajectory of symptoms. We also then use the PHQ-9. So we're all familiar with the PHQ-9. It's used for depression screening, diagnosing, monitoring, measuring symptoms consistent with major depressive disorder. What's very handy is that it's been validated for use in TBI. So a lot of the depression studies that have looked at depressive outcomes after traumatic brain injury have used the PHQ-9 scale. And as you may be familiar, it ranges from mild, moderate to moderately severe. And we considered a significant score if somebody had scored 5 or above on the PHQ-9. Finally, we looked at the Glasgow Outcome Extended. So this is a scale that essentially looks at functional recovery after a patient has had a hit to the head, which really refers to a return to daily life activities such as working, integrating back into the community, social integration. It's characterized on a scale of 1, which is essentially dead, to 8, which is upper good recovery. And for the purposes of our analyses, we dichotomize this variable to consider anything 7 or less as incomplete functional recovery, whereas a score of 8 was defined as complete functional recovery. So that's kind of how we were looking at this cohort. If patients had anything less than 7, it was incomplete functional recovery, and 8 and above was complete. So there are several analyses that we have looked at with this particular cohort, which I'll go through in a stepwise fashion. Firstly, to understand the timeline, so patients were coming into either ER, JHH, or the Bayview ED with blunt head trauma. So nobody with a penetrating injury would be eligible to enroll in the study. And within 24 hours, blood biomarkers were obtained. The GOES was also obtained at baseline. But essentially what we ended up doing was following them at 1, 3, and 6 months and tracking their Rivermead, PHQ-9, and GOES scores at each time point. So the first analysis that we've done, and Dr. Eva Keatley, who is a graduate of the Neuropsychology PM&R Fellowship and now on faculty, worked on this project, and I was the senior author on this, and it's unpublished data at this time. But we were looking at sort of the longitudinal trajectories of who was developing in this cohort of 500 people post-concussive symptomatology. So this diagram shows the distributions of the Rivermead scores for the overall sample of 500 across the 6-month time point. And as you can see at baseline, the scores were quite high or higher than they were towards the end. So there was a progressive decline in score number, which reflects a progressive decline in score severity and symptom severity. We then use group-based trajectory modeling to look at whether or not this cohort of 500 participants would be able to sort of parse out some kind of pattern of individuals whose symptoms persisted, didn't change, or worsened. And what ended up resulting was that there were sort of 4 groups. The first was the minimal PCS group. These are individuals who scored anywhere from 0 to 12 on the Rivermead, and they comprise about 9.1%. The second group were those that had mild symptoms that were acute and decreased over time, which constituted about 44.7%. The third group were those that had high acute symptoms, but then had decreasing symptoms over time, about 32.8%. And the last group were those that had high symptoms, but those symptoms continued to persist and worsen over time. As you can see, the scores kind of go higher towards the end at the 6-month time point. What we found when we were analyzing group membership is that the group that had the highest number of people in it were those that had mild symptoms but were acutely decreasing over time. So this is the 44.7% that you see. So we can say that if there are symptoms that are high early on, that those people may be likely to worsen later on, and that if there's someone in the mild range, that they're likely to sort of resolve or get better by the 6-month time point. We also asked the question about, okay, well, what's going on with this particular cohort of people that just have mild TBI? Are there clinical variables that are associated with psychiatric symptoms afterwards? So what we did with the 407 mild TBI participants is we divided them into 4 groups. And given the fact that loss of consciousness and altered mental status are required for the clinical diagnosis of traumatic brain injury, we asked the question as to whether LOC by itself, AMS by itself, or the combination of both together would predispose people to poor psychiatric outcomes down the road. So what we found, and just as we had hypothesized, that the presence of both LOC and AMS, which comprised about 127 of the cohort, 127 participants of the cohort, ended up having higher rates of everything. So higher rates of depressive symptoms, post-concussive symptoms, and were less likely to have complete functional recovery. So the presence of both bodes worse for prognosis. Those that had LOC only seemed to have an association with post-concussive symptoms and incomplete functional recovery that was really only significant in the early stage, within the first 3 months. As opposed to altered mental status, those individuals really just had associations with depressive symptoms at the 3 and the 6 month mark. So more of an acute and a chronic contribution, whereas LOC is just acute. So this kind of told us that asking about LOC and AMS is really important, because having two together really can determine who is and who isn't likely to develop symptoms down the road. This year, we published a paper on depressive symptoms. So kind of moving along with the story of the trajectory of people who are getting worse, how does psychiatric symptomatology impact these individuals? So we took the cohort and we divided them into those who developed depressive symptoms, who are scoring 5 or above on the PHQ-9 at any of the 3, 1, 3, and 6-month time points, versus those who did not have any depressive symptoms. And when we compared the Rivermead as well as the GOES, looking at post-concussive symptoms and incomplete functional recovery, we found, as we had hypothesized and what has been suggested in the literature, but not really looked at in first-time mild TBI, was that depressive symptoms group had more post-concussive symptoms and was less likely to have complete functional recovery. So the presence of depressive symptoms really can be problematic when it comes to recovering and having longitudinal symptoms. We then took this cohort, and out of the 500, about 217 had first-time mild TBI. So this is actually the first study that's looking at individuals who have had no prior traumatic brain injury, no prior psychiatric symptoms, and looking at it from a standpoint of comparisons of recurrent depression versus new onset. And what we found was that there was 26 individuals that actually did develop symptoms of depression that were new in onset. And when we compared them to individuals who had recurrent depressive symptoms, in other words, these are people who may have not had a TBI before, but they may have had a diagnosis of major depression early on. When you compared the two, we would see that there was really no difference, no statistically significant difference in post-concussive symptoms between two groups. And there's also no difference in functional recovery. So it really doesn't matter if you had symptoms that were new in onset versus recurrent depressive symptoms. Basically, the presence of depressive symptoms in general were what were associated with longitudinal outcomes. We then asked the question, so what's going on from a sort of a brain standpoint? Is there something pathologically that's happening? Towards the very end of the HeadSmart study, we were able to acquire neuroimaging on 8 participants. And of the 8 participants, 5 of them met criteria for mild TBI. So this is a very pilot example of looking at a comparison of functional connectivity in TBI versus controls. Because of the literature that has described the default mode network as being implicated in depressive symptoms, as well in idiopathic depression, as well as in TBI in general, we compared the mild TBI cohort of 5 individuals to those who were in the control group. And looking at Z-score comparisons with an ICA analysis, we saw that there was generally lower within DMN network connectivity as compared to the control group. So this is sort of a basis for us to launch the next question, which is what my current NARSAT is about, which is longitudinally tracking individuals with mild TBI who have TBI for the first time and ascertaining whether or not there are changes in functional connectivity that might be associated with symptoms such as post-concussive syndrome, post-concussive symptoms, or depressive symptoms. So what did we learn from the HeadSmart study? So the first is that there's a measurable percentage of people with acute and mild PCS that do experience improvement over time. If we're tracking early changes in PCS scores following mild TBI, it may be useful in the clinical management later on. It's really important clinically to ask about LOC and AMS in the clinical evaluation, because it appears from what we learned in our study that the presence of both is actually a worse prognosis. And PCS and functional recovery are worse in individuals who actually develop depressive symptoms. So the comorbidities and the coexistence of those symptoms, of depressive symptoms, can actually impact PCS and functional recovery. And finally, exploration of functional connectivity, perhaps in the DMN, may inform of treatment targets later on, particularly in patients who are refractory to psychotropic medications. So now we'll pivot to talking a little bit about management of mild TBI symptoms. So I'll say, as a TBI neuropsychiatrist, the majority of my work is doing collaborative care. So I'm quite often interacting with PM&R, with audiology, with neurology, with pain management, neuropsychology, and sleep medicine. There is an aspect of neuropsychiatric care of these patients that has to be very well thought out in terms of coordinating care, because medications that we might be prescribing might be interlapping with anti-epileptics, for example, that neurology is prescribing, or medications for pain that PM&R might be prescribing, or something that sleep medicine is doing that might be impacting the patient's sleep architecture. So there is quite a bit of integrated multidisciplinary care in the management of mild TBI symptoms. Now, there's not much that's been studied from a pharmacologic perspective. So in 2020, Barry Nair-Peretti, one of our former neuropsychiatry fellows, and I and a larger group published a systematic review on treatment of depression after traumatic brain injury. And typically speaking, with depression being the most common, we found that it's been the most studied, firstly, in randomized controlled trials, and the SSRI, sertraline, and citalopram seem to have the most efficacy. Methylphenidate has had 1 or 2 studies also that have shown some positive changes in depressive symptomatology. For those who might have been veterans or have suffered blast injuries and suffer some sort of traumatic stress afterwards, sertraline has also been deemed to be useful in these patients. When we look at sort of symptom-targeted approaches in terms of insomnia, Ramelteon and Trazodone are 2 agents that are often used. Apathy is something that you always want to be thinking about. It's really a syndrome in and of itself. It's the person that doesn't care, but they don't care that they don't care. So it's really this amotivation and lack of desire to do things, but there's really no caring that they can't do those things. And methylphenidate has really been deemed to be very helpful. For memory deficits, donepezil is currently being studied, and there's more evidence coming out that even for young patients, anywhere from 18 to 45, that they can have some improvement in recall, short-term and long-term recall with long-term donepezil use. Executive function deficits can markedly improve with amantadine. A study that was done, unfortunately, only in severe TBI, not necessarily in mild TBI, has shown that processing speed can improve, as well as task initiation and task completion. And with problems with attention, we can always turn to methylphenidate as well as lisdexamfetamine, which has been studied as well in mild TBI. And finally, we want to be paying attention to the neurological symptoms. So while neurology will often be managing these symptoms, gabapentin, tricyclic antidepressants are ones that have really been looked at most closely. Gabapentin is kind of on the rise nowadays when patients are coming in reporting post-traumatic headaches and dizziness, as well as photophobia and other types of neurological concerns. Other interventions that are being discussed, supplemental interventions, I should say, N-acetylcysteine is one. So NAC is something that we do try in our clinic on some patients. Piracetam, branched chain amino acids. Hyperbaric oxygen therapy has proven some benefits. Unfortunately, there's nothing in Maryland that we can refer patients to, but there are clinics that are developing around the country. Dexabanol did have one study that had negative results, but it is being considered, as well as other interventions such as physical therapy, cervical vestibular rehabilitation, aerobic exercise, and neurostimulation. So this is something that's happening across the country. Several sites are looking at TCS, rTMS, and starting to figure out whether depressive symptoms after concussion can help if pharmacologic agents aren't really working. From a psychotherapeutic standpoint, because we want to kind of look at patients holistically, we want to think about rescripting the perception of life events. If we use things like cognitive behavioral therapy, we have to be mindful that we're tailoring it to the patient's cognitive needs. So CBT really should be tailored to the TBI patient, so to speak. Supportive therapy is also something that's often very helpful that we do in our clinic with our therapists and deliver such excellent care in this area. Behavioral activation therapy and cognitive rehabilitation, which have been very useful. And we often refer our patients to our colleagues in PM&R downtown who have a very comprehensive program for this, as well as family therapy and substance abuse counseling. So these are all the things that you also want to be thinking about as you're thinking of psychiatric medication management. Now, when you look at a rehab standpoint from a psychosocial rehab and a psychiatric rehab aspect, it's multimodal as well. So even within psychiatry, we have to sort of break down what skills we're helping the patient develop. So occupational therapy skills in terms of helping patients with sensory integration, task initiation can be very beneficial. skills for social reintegration, how to develop the ability to not blurt things out and engage in a conversation meaningfully, getting back into the workforce through vocational rehabilitation. Mindfulness-based cognitive therapy is something that's very helpful. And then providing psychoeducation to caregivers. So caregivers often come to our clinic very burdened by what their family members are going through. So sort of educating them about what you can expect for your family member and what's the trajectory going to be like. And finally, anger management, how to deal with impulse control and being more mindful of emotions as they progress in response to triggers. So to that end, we had created the Head Injury Outpatient Psychiatric Enhanced Services, or HOPES program. This is something that was originally created by Dr. Bani Rao, who was the former medical director of the Brain Injury Clinic. And the goal of HOPES is really to minimize disability and maximize function and productivity in any patient with acquired brain injury. So we take patients who don't just have a TBI, they have strokes, seizures, tumors. But the idea is that it sort of encompasses this multimodal approach that I just talked about in terms of OT, mindfulness, anger management, pharmacologic management, psychotherapy, all together. Patients in the HOPES program come through for a 12-week course, and typically it's 3 days a week. Patients can come 3 days a week and see their therapist weekly, their psychiatrist weekly, and then engage in groups of anger management, OT, psychoeducation, etc. We're also now building it to involve more family participation because we're finding that families are actually the ones that we have to end up treating very often. And that's what makes it much more holistic and comprehensive, and patients do enjoy that. We do have sort of the 3A's mottos, which is the hopes to advance wellness. We not only talk about how to psychiatrically and psychosocially manage their issues, but how can they be better individuals in terms of their health, how nutrition, diet, and exercise. We often focus on accepting disability. So we kind of use the position that we may not get you back to where you were, but we can certainly get you better than you are now. And finally, attaining the maximum potential. So, we know what your skill set is now, we know what your strengths are, how can we maximize this? And really the HOPES, being a sort of intensive day program, aims to reduce hospitalizations, reduce the ER visits, because again, because of the pervasive vulnerabilities of disinhibition, aggression, and irritability, patients can be hospitalized very frequently. And also rapid symptom stabilization in a safe and well-monitored environment. So HOPES all around, outside, it's based out of the community psychiatry program at Bayview, really does seek to treat patients in a structured, time managed from a 12-week progression setting to see if their symptoms get better. It's been a very great training ground for the fellows and the medical students and the residents that come through. And it's also good for research. So now we're able to track outcomes in various measures as to whether patients are getting better when they finish the program compared to when they started. We get patients from everywhere, from the adult psychiatric PRP, we get them from our colleagues in PM&R that I mentioned, the outpatient neurorehabilitation program, the inpatient psychiatric unit refers people to us. There's also people who are seeing case management and getting vocational counseling as well as substance use through the PRP are also referred to us. Patients can also come from outside. So we've had several patients that come from outside the state of Maryland just to do the 12-week course and then go back to their providers. So it really is a comprehensive program that is aimed in maximizing ability in patients that have suffered brain injuries. So where are we headed in terms of future directions? So the first is, as we describe a program like HOPES, we describe a program like the PM&R rehabilitation program downtown. Integration of these types of sites is key because patients oftentimes are going from psychiatrist to neurologist to PM&R to their therapist, and really having integrated sites, sort of like a one-stop shop, would be most beneficial. Intensive psychosocial rehab programs like HOPES, kind of building more and more across the country, would be also of benefit as families can start to learn more about what they need to be doing at home for their family members. Early screening through novel neuroimaging after acute injury is also very important. So this is a large reason and large impetus as to why we developed the NARSAD study that I'm currently doing, which is to look at any type of acute changes that happen early in the course of injury. And if we can find out what's happening early on at the time of presentation, then we can sort of set people up to either get referrals to psychiatry or referrals to neurology. And most importantly, it can tell us who's likely to develop symptoms later on in the course. Neuromodulation, as I mentioned, is an up and coming thing. The good thing about doing resting state fMRI studies, as I had alluded to specifically with the default mode network, is that you can start to see potential targets that we can use for neurostimulation in patients who psychotropic management may not be beneficial. And finally, sort of the future of treatment trials. So glutamatergic agents are kind of on the rise. People are looking at vortioxetine, levomilnacipran, and finally ketamine as a potential intervention for patients, again, who are refractory to standard psychotropic medication management. What we have looked at is specific areas. So this is Gustavo de Medeiros. Medeiros is a former Mood Disorders Fellowship graduate. We published a systematic review on depression and neuroimaging correlates. And we are finding that it's really the specific areas in the anterior cingulate as well as the prefrontal cortex that are defining distinctions in depressive symptomatology in patients who have depression after TBI as compared to idiopathic depression. So this is something, again, like I mentioned with resting state fMRI studies, a place that we want to be moving towards and targeting. So in summary, a measurable minority of people still persist with post-concussive symptoms, and they can be very debilitating. Pharmacologic intervention should be conservative, but we want to look at interventions that have been studied and have some evidence for its use. Psychosocial and multidisciplinary collaboration with rehab is really essential, and it's key to getting patients better. And targeted neuromodulations with these particular areas is really the next step. I want to thank all of my mentors, Dr. Leketzos, Dr. Bechtold, Dr. Rao, and Dr. Rosenberg, as well as my colleagues, Matt Peters, Fred Corley, and several others that were on the HeadSmart study for all of the projects that I presented today. And I'm hoping that we can walk away from this conversation thinking about the fact that even though a head injury or a brain injury might be mild, that it can have debilitating consequences later on, and that there really isn't anything mild about mild TBI. Thank you.
Thank you, Derek. That was a great talk. Really interesting, and the HOPES program in particular certainly was very encouraging. It seemed awfully promising. Well, I have a couple things on my mind, but I guess maybe I'll ask you first. You talked about the idea of outcomes data. Is there outcome data at the moment suggesting that HOPES makes a difference for people?
So at this time, so no, because with the COVID pandemic, we had to actually put it on hold. So that disrupted sort of the longitudinal collection of the scales. What we are looking at is several measures: the acquired brain injury symptom scale, the post-concussive symptom scale, and PHQ-9. Generally speaking, we see that patients are getting better, but they have to come consistently and they have to come regularly. And that's we found as an issue. And then COVID, of course, interrupted that. Right, so far, it's still a work in progress.
Okay, great, thanks. Well, let's see. Geeta Jairam says, does the age of injury matter? I don't know if she was referring to a particular part of what you were talking about there.
Yeah, so when we looked at the post-concussive risk factors, what's been studied so far is the two spectrums of the age. So the ones that are younger and the ones that are older. Typically, people above the age of 65, as we start to see sort of normal age changes, can be more vulnerable to neuropsychiatric outcomes. So getting a TBI older is not the best for prognosis. So I think that's kind of where I would leave that answer.
Okay. Russ Margolis says, an important line of work. Is it possible to generate a control ER group who presented with something other than a head injury to help you sort out specific versus non-specific factors in mild TBI?
Yeah, that's an excellent point. And that was one of the biggest challenges that we had in HeadSmart. What was good with HeadSmart is that we had what we call healthy controls, and healthy controls were sort of divided into, and basically healthy implied that they didn't have a head injury, but there were orthopedic controls who had a body injury as well. So we sort of weeded out those that might be suffering from body injury and pain. And that's actually the next analysis we're going to be doing, is pain and TBI later on. But so sort of dividing it into two groups of controls that had no head injury, no body injury, and a group that had no head injury and body injury. So we do have that.
Yeah, that's a smart way to go about it. Joe Bienvenu says, Durga, thanks so much for this talk. Important clinical research and a clinic to which we can and do refer patients and families. Do you have any problems with funding for the clinic, or are you able to collect enough via billing to sustain it?
Great question. No funding. So I think what saved us, and I think I'm very grateful to the fact that the clinic is embedded in the community psychiatry clinic. So, we are in the infrastructure of CPP, which sort of protects us in that way. We've got patients coming in, there's a long wait list. It really has sustained itself, so for the most part, but it would be nice to sort of continue to grow the program with additional funding, I think.
Mm-hmm. Great. And Shadia Onike says, well done, Durga. Regarding neuromodulation, what is the target? Depression, other neuropsychiatric states, or cognition? How does this inform stimulus parameters?
Great question. So this is exactly what I'm seeking to find out with the NARSAD. So what we've seen preliminarily, there's been a couple resting state fMRI guided neuromodulation studies that have been done that have looked specifically at the SGACC. So the anterior cingulate is something that is of interest to people. And so some of the RTMS studies that have looked at just the dorsolateral prefrontal cortex at large had mixed study results with very minimal and negligible effect sizes. But if you actually target within the DMN and you look at the SGACC, we have found that there is some improvement. So I think those are where people are leaning towards guided fMRI guided neuromodulation studies towards, I think so.
Well, let me continue down that vein of what's happening in the brain, just because I think I know the answer to this, but I'll make sure. You talked about axonal shearing as being one of the things that people think happens in mild TBI. And I presume that at least acutely, that's not something that you can see on imaging. Is it something you can see later on? You can see
it later on DTI, but one thing that's really important to think about is it is not going to appear immediately, which is why we are currently scanning people a month out. So within the first 72 hours, you may not get too much, but you'll see between the 2-week and the 4-week mark, you will start to see some changes.
And are those changes consistent with the what you were referring to in your results? What I'm trying to remember, was it decreased functional connectivity?
Yes.
Yeah. Okay. Interesting. All right. No, wait, is this Chadi asking a second question? In structural neuromodulation, how might one deal with the heterogeneity of the head traumas?
That's a tough one. That really is a tough one, because I think that first of all, I think it's the best thing to do is to sort of divide them into severity group, the milds together, the moderates together, and the severes together. And I think then just looking at clearance, I don't know enough about neuromodulation, perhaps my colleagues can weigh in on that one, but in terms of how you could sort of parse out who would be at highest risk for what type of intervention. But I would definitely keep it as homogeneous as you can by just clumping in the severity of groups together.
Mm-hmm. So Jen Coughlin, who some of you will remember a month ago in Grand Rounds, talked about chronic traumatic encephalopathy. She says, do you have any data to suggest that patients with more than one mild TBI do worse clinically or have worse prognosis?
Yes, that's what I was alluding to when I was referring to the repetitive TBIs. So these are the people who are getting multiple blows to the head. And that's actually the group that's the worst, that ends up doing the worst. If you just get one mild TBI, it's kind of clinically considered maybe like the common cold, most people resolve, but the repetitive hits to the head really do end up having worse prognosis. And then the older they get, it's even worse. So hence the reports on the CTE distributions of the former NFL players.
So in the clinical setting, I think I asked Jen Coughlin a question like this a month ago. In the clinical setting, are you sometimes in the situation where you sort of basically want to tell somebody they need to stop doing what they're doing? I think we were talking about football a month ago, and that's one obvious example, although there are probably others where a person puts themselves in a situation where they're at risk of getting these concussions. Are you sometimes pretty directive in telling them they need to stop?
Yeah, it depends on the age of the person. Majority of the people that end up coming to our clinic end up being much younger, and they sustained it because of a sports related concussion. And they're quite debilitated that they can't even go back to work. So it's not been a common conversation that I've had, but we do sort of have to be gentle and careful how we're working with, sports organizations and what we're telling not just players and team members. I have had a handful of people I've had to advise caution, but majority of them are already just so debilitated from all aspects, not just not playing sports, but they can't work, they can't go to school, that they're pretty much taking a break from most things.
Yeah, that makes sense. Thanks. Ray DePaulo says, Durga, it's very helpful to hear about the original source of the CTE pathology. Could you repeat your note regarding Corsellis's report? Was that his paper on dementia pugilistica?
Yes. So yes, that's a good point. So the dementia pugilistica was actually Millspaugh was the one that coined that term in 1937, kind of a progression from Martlin's punch drunk syndrome. Corsellis came behind all that and after that and said, there's a neuropathological distinction to this particular syndrome, which looks at the septum pellucidum abnormalities, loss of Purkinje cells, and the degeneration of the substantia nigra. That's where we first start hearing about neurofibrillary tangles, diffuse neurofibrillary tangles in the cerebral cortex, and no Lewy bodies. So it was really Corsellis that took Millspaugh's dementia pugilistica concept and defined it more neuropathologically as distinct.
Great, thanks. And Paul McHugh says, do our elderly patients with presumed reduced neuronal reserve do worse cognitively with a given TBI? Because an old clinical view was they aged after an injury.
Yeah, that's a great question. The elderly is definitely not my area of expertise. Matt Peters works a lot on this particular patient population. And my suspicion would be yes, just because there's already sort of a vulnerability there in terms of sort of neurodegenerative decline. So I would presume yes, but I'm not too familiar with the data that's there in that particular area. And Matt would definitely know more.
Yeah, I'm looking to see if Matt is on, and I don't think he is. But Matt, if I'm missing you and you want to chime in, please do. No? Okay. Anyone else have insight on that particular issue? Well, let me ask you one more question, Durga. You talked about depression, and of course, you spent a lot of time working on depression. But I think at one point you talked about data that said that whether someone had depression beforehand or not, either way, they did less well. And I guess, my first thought there is, well, that certainly makes plenty of sense, because people with depression do less well on almost any functional assessment of anything. Which is to say, I guess what it makes me think is are we talking about that general effect that depression tends to have on people's function, or is there, or do you think there's a specific kind of pathophysiology associated with depression? Now, you did make one. You talked about Gustavo's study that did talk about a distinctive pathology and depression here.
Yes. So I didn't present it today, but Dr. Rao and I did publish on new onset depression in individuals with all severities of TBI back in 2017. And we did find that there was when you compared people that had new onset depression versus those who had recurrent depression, that the factors that really influence the development of the presence of new onset symptoms was really social impairment, social functioning. Gustavo's paper and more of the neuroimaging work that's coming out is, I think, leaning more towards whether or not there is some kind of damage that's happening within the default mode network that might be associated with depressive symptomatology, as I mentioned earlier, particularly in the SGACC. And could this group be distinct from those who have recurrent depressive symptoms? So they had major depression before, they had a brain injury, they have depressive symptoms after. What's different on functional connectivity parameters with those people compared to those who had no prior depression and then developed it later on? And the big problem just in general with neuroimaging and TBI is you have no clue what the brain looked like before the TBI. So you have no clue what their DMN looked like before the injury. So that is a challenge, but that's actually exactly what we're comparing. And Gustavo's paper highlights that as well in terms of areas of the SGACC and the prefrontal cortex. So we'll see what we get with our study.
Interesting. Well, with that, I want to thank you again for a wonderful presentation. Thanks to everybody for spending the time with us this morning. Hope everybody's a great week. See you all again next Monday. Take care.
Thank you.
Thanks.